Hey students, Instructor Hannah here, and this is going to be our very first injection lecture. Okay. So, welcome to injections, injection basics. So, giving injections is both a skill and an art. And we must have the knowledge to give injections correctly. We need to be able to build a rapport or a relationship with our patient and their family. We need to have effective communication. We must be able to inform our patient what we are giving them and what it is for. It's really important to be able to provide comfort, especially to pediatric patients. We must work safely, and we must document correctly. Medical assistants and the law. Remember that a medical assistant must work under the license of either a physician or a nurse practitioner or a physician assistant. Not only immunizations, but all medications that we administer and tests must be ordered by a licensed provider, such as an MD, DO, NP, or PA. And we must have this order before administering a test, immunization, medication, anything. The ordering provider should ensure our competency in administering the medication or immunization correctly. And mistakes must always be reported to the ordering provider as well as your supervisor. Now, mistakes will happen. We are human. It happens. The most important thing is to not be too scared, nervous, or embarrassed to report it, because not reporting it will do much more harm to the patient and to ourselves. Okay? Why do we give injections? One is for disease prevention, such as vaccines, immunizations. We do tuberculosis testing by injection. There's certain injections we need for school, work, camp, travel immunizations. If you're going to a certain area of the world, then you need certain immunizations. Allergy testing and treatment. Diabetic treatment, such as insulin. Anticoagulant treatment, which is a blood thinner. Heavy-duty antibiotics we can give via injection. These will start working much faster than oral antibiotics. We can give vitamin injections if somebody's very deficient on vitamins. We can inject hormones. And then the standard treatment for anaphylaxis, epinephrine, is often given via injection. Okay, so let's have a little review of our bloodborne pathogen terminology. Remember our BBP from last semester. Pathogenic means that something's capable of causing disease. A pathogen is a microorganism that produces disease. So those two are kind of intermixed, right? A bloodborne pathogen is a pathogenic microorganism that's in human blood that can cause disease. Asepsis means that something is free from infection and pathogens. Medical asepsis, this is a practice that we use to reduce the number of and lower the transmission rate of pathogens. Hand hygiene is the process of cleaning or sanitizing our hands. Antiseptic is an agent that's applied to body tissue or objects that can kill disease producing microorganisms. Parenteral means that something's taken into the body through piercing of the skin or the mucous membranes. So basically needles, right? Injections. Contaminated means that there's the presence of blood or other potentially infectious materials on an item or surface. Remember, we call those OPIM. A safer medical device. This is a device that would make an exposure incident involving a contaminated sharp less likely. Personal protective equipment, or PPE. This is clothing or equipment that protects an individual from contact with blood or other potentially infectious materials. OPIM. Occupational exposure. These are reasonably anticipated skin, eye, mucous membrane, or other parenteral contact with blood, or OPIM, that result from the performance of an employee's duties. So occupational means at work. An exposure incident is when a specific incident occurs, something with the eye, nose, mouth, other mucous membrane, non-intact skin, or parenteral contact with blood, or OPIM, that results from an employee's duties. So these two can get confusing often. So occupational exposure is basically the risk, right? So we know as medical assistants that we are faced with occupational exposure every day. The risk is there of becoming infected with blood or OPIM during our jobs, doing our duties. So that's the occupational exposure. So it's reasonably anticipated that this could happen, right? I can go many years without having an exposure incident, even though I have occupational exposure every day. So when that actually happens, that is the exposure incident. When something actually occurs and you are, in reality, potentially infected. Okay, so OSHA is the Occupational Safety and Health Administration. This is the governmental body that established the bloodborne pathogen standard in 1992 to help employers provide a safe and healthy work environment for employees and reduce their risk of exposure to infectious disease. So, standard precautions, more review. These are a set of infection control practices issued by the CDC to help prevent infections in healthcare settings. The standard precautions include hand hygiene and gloves to prevent transmission of diseases that can be acquired by coming into contact with blood, body fluids, secretions, excretions, non-intact skin, and mucous membranes, as well as rashes. There's a typo right there. These measures are used when providing care to all individuals, whether or not they appear infectious, whether they have symptoms, whether you know if they have HIV positive or not. Okay, so we always apply standard precautions every time we see a patient, no matter what. Okay, we treat them all the same as far as hand hygiene, wearing of gloves, etc., to protect them and protect us. We don't need to go digging around in their chart to see if they have any communicable diseases, because we just always use standard precautions. So we're always safe. So doing this reduces the risk of transmission of microorganisms from both recognized and unrecognized sources of infection. Under standard precautions, blood and certain body fluids of all patients are considered potentially infectious, right? So it doesn't matter if I looked at that patient's chart last week and I ran an HIV test on them and it was negative. If I'm drawing blood again this week, I am going to consider it potentially infectious. Okay. So aseptic technique, that is a set of specific practices and procedures that are performed under carefully controlled conditions with the goal of minimizing contamination by pathogens. The purpose is to maximize and maintain asepsis, which is the absence of pathogenic microorganisms in the clinical setting. The goal is to protect the patient from infection, and us too. We like to be protected as well. Engineering controls. These are controls that isolate or remove health hazards from the workplace to eliminate or minimize the risk of occupational exposure. Remember, we always have that risk, but we can have controls put in place to help eliminate or minimize the risk, such as having hand washing facilities easily accessible, having safer medical devices, having biohazard sharps containers close by, using biohazard bags. Okay, those are the engineering controls. Work practice controls, these alter the manner in which a technique is performed to reduce the likelihood of exposure. So both of these are to reduce risk of exposure, right? But these are things that we actually do. Okay, engineering controls are things that we use or things that we set in place. And work practice controls are something that we are practicing, okay, such as observing the biohazard warning labels, okay, putting bandages over any cuts that we might have on our hands before putting on gloves to treat our patient, sanitizing our hands before and after every single patient contact. Those are our work practice controls that we do every day, all day long, to minimize risk. Wearing appropriate PPE, personal protective equipment. Never remove, recap, or bend a contaminated needle, right? Just don't do anything with it. Once your needle is contaminated, the only thing you should ever do is put it in the sharps. Immediately disposing of contaminated needles in a biohazard sharps container. So these are things that we can do, that we can control, that minimize our risk, right? So these are kind of like actions that we get to put into place every day. You should never, ever store your lunch, food, drinks anywhere in the lab, okay? None of the refrigerators, freezers, cabinets, or shelves where any blood, OPIM, or honestly any medications, vaccines, nothing, okay? No food or drink should ever be in any lab area, ever. Okay, and then if exposure does occur, make sure you perform first aid measures immediately. That is always the first thing you should do, right? If you get an accidental needle stick, you're not gonna drop the needle and run and go show your boss, right? You're going to perform first aid first, immediately. Okay, so infection control principles. The MA should always follow both the standard and universal precaution guidelines. The MA should always use aseptic technique. Hand hygiene should always be performed before and after contact with a patient. And selection of our PPE will depend on the type of patient interaction, okay? If you're working in a more hospital type setting, it's going to depend on what precautions that patient is on, right? If they're on droplet precaution, airborne precaution, etc. Always, always wear gloves when handling any blood, any body fluids, and non-intact skin. Okay, so we have our use sharps disposal guidelines. You will go over this in the lab with Ashlyn as well. So all of our needles in the lab have safety devices on them. Okay, these are engineering controls to help keep us safe. These should be activated immediately after use of the needle and immediately discard the whole thing, needle and syringe, in a sharps container, right? So you're going to give an injection, you're going to withdraw, you're going to activate your safety, and you're going to put it in the sharps. All just kind of one smooth motion. The sharps container should always be leak-proof, puncture resistant, and either red or orange, something really bright, right? And they should always be labeled with a biohazard label. Used needles should never be recapped, bent to the side, cut, or removed from the syringe. Don't ever mess with a used needle. And don't ever overfill those sharps containers, okay? They need to be locked up and discarded after they're 2/3 of the way full, or when the contents are at the full line, which is indicated on the containers, should be about 2/3 of the way full. All right, so let's go over some key terms of injections. A drug. So this is what we refer to any chemical that we use for treatment, prevention, or diagnosis of disease. Okay, so I know it can be a little strange, to go to work and hear people talking about drugs. Well, what drugs have you tried? What drugs have you given them? Because we just immediately assume that we're talking about something illicit or illegal or something you buy on the street corner or something, right? So in medicine, drugs are what we give patients every day, all day, right? So it's not a bad word at all. Dose is the quantity or amount of the drug to be administered at one time. So each administration has a specific dose. A vial is a closed glass or plastic container with a rubber stopper that can hold either single use or multiple doses of a medication or immunization. An ampule is a small sealed glass container that holds a single dose of medication. Reconstitution is the process of adding a liquid to a powdered drug. Okay, so some drugs are manufactured in powder form because they last a lot longer and they don't go bad, So you reconstitute it right before you administer it, make it liquid. The diluent is the liquid that is used to reconstitute a powdered drug, and it's usually sterile water or saline. Okay, so there are 3 injection types. Intradermal is when the medication is being introduced just into the dermal layer of the skin. Intramuscular is when the medication is being administered into the muscular layer of the body. And subcutaneous is when that's administered beneath the skin and then into the fatty layer of the body, which is adipose tissue. Okay, so it's in between the dermal and the muscular. Okay, so here's our parts of a needle and syringe. We have the hub. This is the needle right up here at the top. The base is the hub. The hilt is where the metal needle part meets the hub. The lumen is the opening on the end. It's kind of an oval shape. Then you have the point at the very tip that's sharp. The bevel includes the lumen and the point. So it's all of them, both of them together. And then just the long part is the shaft. In the syringe, you have the plunger. You have the flange, which is the part that you should always hold it by. Okay. You have the barrel, which is the part with all the measurements on it. And then you have the tip here. Okay, some of the syringes you'll see have a lure lock mechanism. So the tip actually has kind of some threadings on it, like a screw. And the hub of the needle will have the threadings that match on the inside so that it actually screws into place on the syringe. Okay, so we discussed all of those. I was always taught this too, that all injections should be given with the bevel facing up. There's some, and that is true with intradermal injections, always bevel up. But as far as subcutaneous and intramuscular goes, we'll look at the data a little bit more, but I don't think there's any data that shows that that's true. So we can talk about that more. Okay, so when we talk about needles, we are always talking about 2 things. The length, which is how long the needle is, right? So we have really, really short needles and we have really long needles, okay? And this is going to depend on what type of injection we're giving. right? So do we need that needle just to get into the dermal layer? Do we need to get it down further into the subcutaneous level? Or do we need to get it even further into the muscular level, right? So we're going to pick a needle accordingly. And then the size of the patient has a lot to do with it, right? So if I'm, want my medication or immunization to end up in the muscle, in the deltoid muscle of a patient who's very, very, very thin and has very little muscle, I'm not going to use the same size needle as I am as a big, 200-pound guy with big muscular arms, right? And then the gauge, okay? The gauge is the needle opening or the diameter of the lumen, right, which is the opening. And so this can be confusing because the larger the gauge, right, so the higher the number, actually means the smaller the diameter is. And then the smaller the gauge, so the lower number, means that it's bigger, okay? So the 18 gauge right here is actually pretty darn big. You're really not going to put that into a human patient, not too likely. These are great for drawing up really thick, viscous medications that you may have just reconstituted, and then putting on a smaller needle that's appropriate for your patient size, right? And then 25 gauge is kind of standard. That's a pretty reasonable size. Okay, I think we talked about all of those as well. Okay, so the hypodermic syringes, these are used most oftenly to administer IM injections, intramuscular. Okay, and typically the barrel, the amount that it will hold will be 2 mLs, 3 mLs, or 5 mLs. Okay. You'll also see it calibrated in cc, which is cubic centimeters. Milliliters and cubic centimeters are equivalent, right? So 1 ml is the same as 1 cc. Okay. Yeah, cc's, that's kind of an older term, and you don't see it as often. Milliliter or ml is more commonly used. So this is a 3 ml syringe. That's the total amount that we can put in there. Okay. We also have insulin syringes in the lab, and your very first injection, you're going to be injecting yourself subcutaneously in the abdomen with an insulin syringe, just like diabetics do every day. Okay. But insulin syringes are calibrated special. They are calibrated in units, which is different than a milliliter or a cc. Okay. So typically you'll see either a 100 unit syringe or a 50 unit syringe. Okay, if it's in 100, usually each tick calibration is 2 units, and if it's the 50, then they'll usually be in increments of 1. Every insulin syringe that you see should have an orange cap on it, okay, to indicate that it's an insulin syringe, and you should not be using it to draw up a regular medication or immunization. Okay, so we also have special tuberculin syringes, right? And these are what we use most commonly to administer the MAN2 PPD, purified protein derivative tuberculin tests. These are the old school TB tests for tuberculosis that we do intradermally, right? And they make that little wheel. And you've all probably had it done before. So these are very small. Their capacity is 1 ml, and their calibrations are divided into tenths and hundredths of that milliliter. Okay, so we give a very small amount of medication. For the PPD, if we're administering a PPD, it's always just 0.1 mLs. So it's actually quite bigger than we even need it to be, but they're pretty small. Okay, so vaccine information statements, the VIS. All right, these are put out by the CDC, and they are updated periodically. They're always going to have a date on them, and so you have to make sure that you are always giving it to your patient or your patient's caregivers, parents, or whoever their guardian is, legal guardian. It's required by federal law, okay? There's the National Childhood Vaccine Injury Act of 1986 that says that we have to provide this to the patient, okay? It provides information about the benefits and the risks of the vaccines. We should be giving this to the patient before we administer the vaccine, right? It doesn't really make sense to administer the vaccine and say, here you go, now you can read about the risks and benefits of it, but you already have it. So how can people make an informed decision, right? It usually answers most of the patient's questions or the parent's questions, or it will bring up questions for them that they can then ask the provider for clarification. It includes information on potential reactions, kind of like the most common ones to be on the lookout for. So any provider that gives vaccines must give a VIS, okay, to the patient or the parent or legal guardian before administering the vaccine. This is very important. Each and every time the vaccine is given, right? So not just with the first dose. If you're getting the Hep B or Hep A series, you should be provided with that VIS every single dose, okay? And we have to document that. We have to record and document in the medical record that we gave the vaccine, the VIS, and the date on the VIS, right? The most recent version. We always have to give the most recent version. Make sure you're not giving an expired version, okay? That must be documented. At PAMF, you'll see they have them sometimes laminated in the exam room, right? And so then they'll hand it to the patient to look at while they're going and preparing the vaccine, and then come back, and then they can just take it back and put it back on the thing in the wall. They can reuse it, right? They can sanitize it, reuse it over and over, because most people don't actually want to bring the handout with them home. But of course, they should always be given that option. Right? If they want to actually take a paper handout with them home, they should be provided that. Okay, so we're going to take a little break here before we move on to injection guidelines.